Given that dysphagia is often more a problem of poor coordination or timing with the swallow, this is really where an understanding of motor learning can be helpful. So you can really be intentional about how you design your intervention to promote a change in swallowing.
One challenge in dysphagia rehabilitation is the complexity of swallowing itself. Swallowing involves a series of intricate muscle movements and coordination, and it can be challenging for individuals with dysphagia to gain optimal control. Principles of motor learning can greatly enhance dysphagia rehabilitation by providing a systematic framework for optimizing the learning and relearning process and improving swallowing function. In this episode, we talk to Professor Kristan Leech, who's a physiotherapist and expert in motor learning. Kristan explains the key principles of motor learning, how we can best implement them in our clinical practice, and therefore support skill acquisition or reacquisition of our patients. And throughout, we discover many parallels between walking and swallowing. So stay tuned and enjoy listening. Hi, Kristan, and a warm welcome to our podcast, Dysphagia Matters. We're very happy to have you here with us today. Would you like to briefly introduce yourself?
Sure. Yeah, I am Kristan Leech. I currently work at the University of Southern California as an assistant professor in the Division of Biokinesiology and Physical Therapy. And here I run both the neuroscience curriculum for our physical therapy students, as well as run a research lab that's focused on studying gait rehabilitation and motor learning in older adults. And for the most part right now, our studies are focused on people who have had a stroke.
Great. And beforehand, when we were emailing, you told us that your sister actually is a speech and language therapist.
Yes, that's right. She's an SLP in Phoenix, Arizona. Her name is Kendall Arnold. I'll give her a little shout out because she helped me prepare for this interview today a little bit.
Amazing. And so you probably have lots of contact to the SLT field then.
Yes, absolutely. Mm-hmm.
Perfect. We'll dive right into the topic of motor learning. A very common definition of motor learning is the one by Schmidt and Lee from 2005, and it says that motor learning refers to a set of processes associated with practice or experience, leading to relatively permanent changes in the capability for movement. That is quite something. Can you help us understand what this means?
Yeah, absolutely. So I'll kind of break down that definition a little bit, and I'll clarify something that I think was helpful for me, which is the way that we study motor learning is typically by looking at a set of change in behaviors. So, or at least that's how we study it in my lab. There are other ways to study the processes that go into the change in behavior or the motor learning that has occurred. But the definition provided here is really describing the underlying changes in the nervous system that have to occur to elicit this change in a behavior or a movement. And so that's what this definition, this set of processes associated with practice or experience that drives this permanent change in a behavior or a movement.
Yeah, perfect. And I think some of those keywords we will come to again later on when we try to clarify other words.
Definitely, yeah. We will probably circle back around to that definition, yeah.
So why is it important for us as clinicians working in the field of rehabilitation to have knowledge of motor learning? And do you think this is relevant to swallowing rehab in particular, if you have any knowledge about swallowing?
Yeah, I will try not to overstate my knowledge of swallowing, but I will do my best. So I think that this is broadly important for clinicians working in rehabilitation. So this could be physiotherapy, occupational therapy, speech therapy. It doesn't matter the area of practice that you're in. Understanding motor learning for clinicians in neurorehabilitation is really important because it allows you to be more strategic and intentional with your intervention. If you are able to understand those sets of processes that are occurring in the nervous system, given the design of your approach. So you can think about different ways to structure the practice of a task to manipulate the processes in the nervous system that underlie a change in behavior. So I think that that is probably the primary reason that's important for clinicians to have a detailed understanding of motor learning, to be able to intentionally structure their interventions to drive a change in the behavior that they're seeking. Otherwise, I think often as clinicians, we're really good at building our experience over time and starting to intuitively understand what works given a specific patient presentation. And so having this understanding of motor learning, I think actually helps you just kind of map language onto something that you've intuitively come to understand through your experience as a clinician. And that then can help you kind of communicate with your colleagues about what you're doing, or to think a little bit differently as opposed to going purely based on what's worked in the past, if that makes sense.
Yeah, and also using the evidence base that we have and really working effectively and efficiently, I guess, with our patients.
Absolutely. Yeah. So I think there's not a lot of current evidence right now that I can cite that says if you take a more motor learning based approach to your intervention, it is more efficient. But if you are thinking about the current evidence that exists and how you can integrate that into your treatment, it just sort of logically follows that that would be more efficient than trying a lot of things at the beginning and taking time to see what works. So I'm hopeful that the research kind of evolves in that way to demonstrate that, using a little bit more strategy at the front end of developing an intervention or an intervention plan for a patient would lead to getting them kind of out of your care faster. We're not quite there yet. I'm just optimistic about it.
That's good. It's always good. Another reason why we invited you, not only because you're an expert in this field, but I think especially physiotherapists have a lot more experience with motor learning, or maybe more fields in their practice where they work on this, but still, from our experience and from the knowledge we have so far, it's probably quite important for SLTs as well. And I'm already touching on my next question. So in your paper on updates in motor learning, implications for physical therapist practice and education, you write, motor learning has become a fundamental component of entry-level physical therapy education. And I thought that was really interesting. But from my experience, this isn't really true for our entry-level SLT education, or maybe even advanced SLT education. Do you think this is a relevant topic for dysphagia clinicians?
Yeah, I absolutely do. I think that especially after talking with my sister about a little bit more about what dysphagia interventions look like. So I will explain what I currently understand about this, and you can correct me if I go off course a little bit. But from what I understand, many of the current treatment protocols for swallowing or dysphagia are really based on strengthening the muscles that help with swallowing. But the underlying issue of dysphagia is not necessarily a lack of strength. It's more of a poor coordination or timing of the swallow. Is that correct?
Absolutely.
Okay.
And I love that your sister said that. Actually, our next episode is going to be on two approaches. One is strength-based and another one is skill-based. So,
great. Okay.
Perfect preparation for the next episode.
Perfect. Yes. So I think given that dysphagia is often more a problem of poor coordination or timing with the swallow, this is really where an understanding of motor learning can be helpful, because motor learning, if we go back to this definition of the set of processes that are associated with practice that can lead to a change in a behavior, that's sort of assuming that the strength of the muscles is there. You can use motor learning to retrain the timing of the firing of those muscles for a specific desired behavior, which in this case would be a functional swallow. So interventions that are more focused on strength may not improve the coordination of the swallow. That's where I think an understanding of motor learning could be really important for SLTs.
Swallowing is a really complex process. So there's so many muscles involved. And I always imagine it a little bit like walking. There's so many things that you have to coordinate at the same time. And even if your muscles aren't weak, if you have normal muscle strength, it can be still quite challenging if you have a neurological condition to actually walk properly. So the only difference I feel is that you can observe walking from the outside pretty easily, but you can't observe swallowing from the outside that easily. So that might be a major difference.
Yes, that's absolutely right. And as I imagine that's an added challenge from a speech perspective is you can't measure or you can't objectively or subjectively measure the change in the swallow within a session. Do a swallow study, right?
Yeah, or an instrumental assessment. Yeah.
So you have to, that's an added challenge for a speech therapist to understand if the intervention is working. You can't see it right in the session to know if you're on the right track. And so maybe that's even more motivation for why having a deep understanding of motor learning could, in theory, contribute to efficiency of an intervention, given the lag that it would take to assess if change is occurring in the swallow. But I might be kind of speaking out of turn with how things are assessed in speech. I'm not sure.
No, you're perfectly right.
Okay.
As Julia has already mentioned, you and your colleagues have published a paper on updates on motor learning. To our listeners, as always, you can find the reference in the show notes. We feel like we can learn a lot from the physiotherapy profession, as already said, in this regard. And before we discuss your paper in a bit more detail, we think it would be helpful to explain a few general terms related to motor learning so that it will be easier to understand for everyone. In the literature, there are two distinct types of motor learning described, the motor adaptation and skill acquisition. How can we best differentiate these two?
Yeah, that's a great question. And I think maybe one of the most difficult things about understanding motor learning is the different language that is used to describe a lot of different things. And so that's really one of the things we tried to do in the paper was be very clear about the language that we were using and then map the terms that we chose to use onto other terms that you would see in other papers that essentially mean the same thing. So if you're feeling confused, hopefully this paper provides some clarity about that. So motor adaptation is really defined as changing a movement or a behavior that somebody already has and adjusting it given the needs or the demands of a task. So one maybe intuitive example is if you try to use someone else's computer and their mouse cursor is calibrated differently than your own, you sort of have an understanding of how the mapping works on your own computer, but then you realize this person's cursor moves much faster than yours. So you have to adjust your movement to accommodate for that different mapping between the cursor and the mouse. Another good example is if you rent a car and you start driving it and you realize the brakes are much more sensitive than your own car, you have to sort of not step on the brakes as hard and have the car come to a halt. And that takes a few attempts of stepping on the brakes to decelerate the car at a normal pace. And so that's something you already know how to do, but you have to adapt what you're doing to continue to be successful given whatever demands are occurring in the environment. Skill acquisition, on the other hand, is learning to do something from scratch. This is also de novo learning. So learning something that you've never done before. And I would say there's not a lot of clarity on how this differs from someone who has had some sort of injury that has maybe known how to swallow before or known how to walk before and then has to relearn that. That I think often gets bundled more into the acquisition, or people will call it reacquisition or relearning. The waters are a little muddy there to understand if that process, the underlying processes of relearning something are different or the same as learning it from scratch for the first time.
I was just thinking about what we were talking about earlier before we started the recording when I told you that I'm also working with children in dysphagia rehabilitation and that some of them are learning specific movements for the very first time versus older patients or adults who have already known and mastered these movements but have to learn them again for whatever underlying condition.
Yes.
And that this asks for a different perspective on the intervention.
You know, I think one thing that's interesting is this idea of habits developing over time. And this is kind of a different topic, but with older adults, you're battling some movement habits that have developed. And this can be the case, particularly I'm thinking in people with chronic stroke, if they're coming to you after they've kind of already learned how to manage in life, and then they come to your care for whatever reason. Maybe they'd gotten sick again or they need a tune-up or whatever, and now they've developed these movement habits in the context of having had a stroke, and you have to really think about how to get them out of that movement habit and into a different habit. So yeah, it changes across the lifespan what you're dealing with in the nervous system. Absolutely.
Yeah, interesting. Makes it even more complex and complicated.
This just reminds me of compensatory strategies. So in swallowing, sometimes we even teach the patients how to compensate maybe for swallowing difficulties. And sometimes, for example, post-stroke, patients adapt their own compensatory strategy, and they can be good, they can be working, and sometimes they might not be really effective or not working that well. And that might be quite challenging, actually, to get them from that not quite well working compensatory strategy to one that is working.
Yes, absolutely. I think this is actually such a hot topic. It sounds like you're very familiar with, but the patients are, if left to their own devices, patients are quite clever figuring out how to do the things that they want to do. And that is what we've termed that in therapy is compensation, if it's not going right exactly back to how they did it before they had their stroke. There's this, I'm going to get in trouble with the whole field of rehabilitation, but there's this balance between, maybe leveraging some compensation for function's sake, which I think is important to consider. And then also not forgetting that the nervous system is very plastic, and, within a given amount that we don't understand yet, might be able to restore some function through different pathways. I'm speaking specifically about a stroke, but we have to keep in mind too that there are parts of the nervous system that are just fundamentally damaged, and we won't be able to restore those in the context of stroke.
Oftentimes, motor learning is mentioned together with neuroplasticity. Could you explain what exactly neuroplasticity is and how it relates to motor learning?
Absolutely. That's a really good question, and another good example of how the language that we use is so confusing. So neuroplasticity is really defined as the ability of the brain to reorganize itself or change the synaptic connections that are in the brain and in the spinal cord, actually, especially in response to experience. There's neuroplasticity during development that is considered to be activity independent. So connections form in the nervous system according to genetic expression and things like that. But once you're in even treating children or in adults, you're talking about activity dependent neuroplasticity. So this can occur in a nervous system that isn't injured through learning something new or adapting a movement, or following injury, that kind of relearning behaviors that maybe you have known how to do in the past, or adapting your newly learned behaviors. And so that's really more about changes at the brain level, the synaptic connections at the brain. The term neuroplasticity describes the processes, all of the processes that contribute to motor learning or can underlie the change, a more permanent change in behavior that's driven through experience. You can have, let's say in the case of a spinal cord injury, there may be some sparing of axons in the spinal cord that through practice you're trying to promote neuroplasticity to strengthen the spared axons with the injury. But that's all through what we'll talk about in a minute, use-dependent learning for the most part. So it's really the changes in the nervous system that are related to the change in behavior that you see, or that allow for the change in behavior that you would see with some sort of motor learning intervention.
So only if you see neuroplasticity or if you drive neuroplasticity, then we talk about motor learning.
That's right.
Otherwise, would it be motor performance?
Yeah, so, okay.
Sorry, I'm dropping in another term.
No, that's okay. That's okay. The difference between motor performance and motor learning is motor performance is more of a temporary change in a behavior that does not last for long. So let's say maybe a good example that might be kind of intuitive to people is if you have someone come into the clinic and they are able to do something with some kind of feedback, I don't know if like a biofeedback or something, But then when they leave, they go right back to doing what they were doing before. So that would be a change in performance. And that's even more a change in performance, or we're more sure that's a change in performance if the next day they don't change their behavior at all based on what they did in your session. So there's this distinction between motor performance and learning, and the amount of time that the person can keep that motor behavior.
Yeah, maybe one common example from Parkinson's and speech and language therapy is really that people with Parkinson's, if they are cued externally for a louder voice, they can produce it quite easily. So it's, again, probably not a problem of muscle strength, but really this internal cueing. But then if they walk out the treatment room and maybe they talk to their spouse or someone else, they use their softer voice again. So it's really they're performing the treatment room. Sometimes they just see the clinician, the SLT, and they know, okay, I have to talk loud. But when they leave, they're going to use their softer voice.
Yes. So there's one form of motor learning that you could say is the person is using in that situation that you described, which would be instructive motor learning, where they can be given an instruction and then they can do it, right? Or ideally, at some point, then they don't need the instruction anymore, and they choose to do it on their own, or it becomes a habit. But that this idea that they can pull it up means that the capability of doing it is in the nervous system, but it's not their default, if that makes sense. Yeah,
absolutely. Maybe we start talking about your paper in more detail then.
Sure.
So in your paper, you introduce the reader to 4 mechanisms of motor learning, and those are use-dependent, instructive, reinforcement, and sensory motor adaptation-based motor learning. Maybe we start with the first one. Great idea. Use-dependent motor learning. What does this incorporate, and how can we best implement this in our rehab sessions?
Yeah, so use-dependent motor learning is really defined as a change in motor learning that's driven through repeated practice. So this and in a high dose. So in animal studies of use-dependent motor learning, they need thousands of repetitions, or they have thousands of repetitions to show some change in the nervous system, or to elicit neuroplasticity. And so that's most likely the type of motor learning that's most familiar to clinicians is this idea of a change in the nervous system that's driven through practice, purely practice. And I think that this can be best incorporated, and you'll have to tell me about how this applies to SLT, but purely through structuring your intervention to allow for the person to practice whatever the task is that you want them to do as much as possible within that session, but then also providing them a home exercise program that will continue the amount of practice that they get for that motor behavior. Because at least in the States, interventions are about 50 minutes. You get about an hour with a patient, and then they go home, and maybe in an outpatient setting, they come back a few days later and you see them again for an hour. They're living so much life outside of the therapy session. And so I think one of the other ways, now I'm kind of circling back around to another question, one of the other reasons it's important to understand these mechanisms is to educate your patients why it's important for them to do their home exercise program. And so I think being able to get some patient buy-in by explaining what is happening in the nervous system, given what you're having them do, and how you think that's going to link to a change for them, might help get compliance with the home exercise program.
Yeah, and also really the adherence to the treatment. So yeah, if it's an intensive treatment, maybe you're kind of lucky. If you're unlucky, you only see the patient once a week, and then it's even more difficult. But if you're lucky and you can do an intensive treatment, you see the patient maybe 4 times a week, then adherence probably is really key to the treatment being effective in the end.
Absolutely. Particularly if you're really leaning on use-dependent motor learning, right? So you really need the high dosage of repeated practice. The other component, I guess I should talk about with use-dependent learning, is that it really needs to be task specific. So you need to be practicing the task that you want them to get better at. So if you want someone to get better at playing piano, they need to practice playing the piano. Or if someone wants to get better at playing the piano.
I love that one because there's this saying, you can only rehabilitate the swallow if you actually do swallow. And sometimes we tend to do exercises that aren't related to swallowing at all. And I guess those aren't task specific at all then, if
That's
at
right.
least you're aiming to improve the swallow.
Yes, yes. I'm learning there are a lot of parallels between swallow rehab and gait. So with walking, there are different approaches that you can take as a clinician. You can focus on one discrete part of the gait cycle and then hope that that kind of translates into what happens when they're actually doing continuous walking. Or you can simply practice the task and create the constraints in the environment that get them to do exactly what you want them to do, instead of kind of breaking it down and having them just practice. I'm going to use the example of weight shifting from one foot to the other. And so that's the example of task-specific practice, is that continue to work on what you think is the most important part of the swallow or the walking, but do it in the context of the task that you want to improve.
Excellent. Yeah.
How does instructive motor learning then differ from use-dependent motor learning?
Purely use-dependent motor learning. This is maybe a good example of how patients figure out their own compensation strategies, is with no instruction. They just do things and they see what works, and then they develop this compensatory movement. With instructive motor learning, you're providing feedback as the clinician about how to change the movement. You're giving them a strategy to try, and then you're telling them whether or not they were successful if they can't kind of internalize it, or they get visual feedback or auditory whatever sort of feedback about how they did on that trial, for example. And so often what happens is that instructive motor learning is layered on top of use-dependent learning, at least in physical therapy. So people will be practicing a specific task, and then the clinician is providing verbal cues or visual cues about what they would like to see change in the movement that they're doing. One of the benefits of being able to kind of layer different motor learning processes on top of one another is that instructive motor learning, if the person has the capacity to do what you want them to do, is very fast. They can change their performance very quickly from one trial to the next. Use-dependent learning is very slow. It takes weeks for you to be able to see change in the nervous system driven through use-dependent learning. So what I think most often happens in therapy is we use those two in parallel to allow the person to see what their capacity is. And then we use use-dependent learning to try to shift them towards doing that more habitually. Or maybe they don't have the full capacity to do the movement that you want them to do, but you need them to practice it and work towards the edge of their capacity to then change what they're ultimately able to do. So you use both together. And I think maybe that's one really important thing to understand about these processes, is that they're all happening all the time. We talk about them a little bit like they're in these distinct buckets of motor learning processes, but they're not independent of one another. We study them like they are because we'll create these in research, we'll create these really specific environmental demands so that we think we're mostly targeting one or the other. But in real life or in clinical life, they're all happening together. And so you can think then about how your intervention is structured to really maybe leverage using one more than the other, but they're all happening at the same time.
For instructive motor learning, do you need a therapist or someone else telling or showing the patient or giving feedback, or would this also be biofeedback?
Biofeedback is the same. So I think it can be verbal cues from the therapist, or it can be biofeedback, as long as the person understands what they're being asked to do or what the feedback scheme means, then that is considered to be instructive learning. Some people will call it strategy-based learning, where the person is developing a strategy for how to achieve what you are asking them to do. I chose to call it instructive in this paper because that's kind of how gets implemented in physical therapy most is from instruction from a therapist, but it's not necessary that the therapist be the person sort of providing the feedback about their performance. It could be more objective through biofeedback or something like that.
Yeah, that makes absolutely sense.
The fourth mechanism is sensory motor adaptation-based motor learning. What does this comprise?
So sensory motor adaptation-based learning is maybe the most unique one, which is motor learning that's driven through sensory prediction errors. So this is defined as a mismatch between what your nervous system expected a movement to feel like and what it actually felt like. So the best example is one we talked about already, or a good example is one we talked about already of driving a rental car and expecting the brakes to be calibrated the same as your own car, and then finding out that they're not. And the sensory feedback you get is the car kind of like slamming to a halt. And so sensory motor adaptation is, I think, maybe more often used in the context of trying to promote someone's movements to be more flexible given a change in the demands of a task. So I'll talk a little bit about walking, allowing someone to walk over grass versus sidewalk. You have to have some amount of flexibility in your gait pattern to accommodate the unevenness of a yard or a garden that you don't have to have necessarily if they're walking over a level surface. And so a sensory motor adaptation, I think, is most useful to clinicians to kind of fine tune or make a movement that someone already has more flexible, or to maybe make a movement that they have that is not that automatic to be a little bit more automatic, so they don't have to think about it as hard. That is how I see sensory motor adaptation being the most useful in the context of physical therapy, at least. I could imagine, I'm just going to take a guess at how this could map onto swallowing, but if someone is developing a successful swallow strategy or the motor coordination of swallowing, and then you start to change the texture of the things that you're having them practice with, that's more of a sensory motor adaptation approach.
Yeah, the texture, or maybe also the volume.
Yeah, absolutely.
Of the bolus volume. Okay.
Yeah, absolutely. Yeah.
Could you say that the sensory motor adaptation based motor learning approach is also something like generalizing or transferring the skill that you've learned to other conditions, in our case of swallowing, like bolus volume, texture, and maybe also if you have difficulties with cognition, maybe if you're in a room where you have lots of stimuli, so all those kind of things?
Yeah, I think that's absolutely right. I certainly don't know if we've fully unlocked what makes a movement automatic or less cognitively demanding. I think we're still really trying to sort that out, but there is some shift from, and this is sort of the Fitz and Posner model of learning, where it goes from very cognitively demanding to autonomous. And I think that sensory motor adaptation has a role in that, so that you can be in a busy environment or maybe out to dinner with your friends and not having to think about how you're swallowing. I do think that sensory motor adaptation does have a role in that transferability or the generalizability to a broader range of, we'll call it task demands. So the types of things that you're swallowing or the volume of things that you're swallowing. Whereas in walking, for example, it's where are you walking? What are you walking over? And how successful you are in kind of fine tuning your walking pattern to adjust for those changes in the environment.
Yeah, and I think it's so interesting because we as SLTs, of course, don't think that much about walking. And you as physios probably don't think that much about swallowing, because both are just things that we do without paying lots of attention to it, as long as they work all fine. But if we do have a difficulty or maybe a neurological condition and it doesn't work anymore, we really have to pay attention to it. And it's not as easy anymore as it was before.
That's absolutely right. Yeah. There are so many more parallels between swallowing and walking than I acknowledged or knew about before today.
Could you maybe elaborate on why these mechanisms are relevant when working in the field of rehabilitation and what the clinical implications are?
Yeah, absolutely. That's a great question. So I think Probably the primary implication that's important to understand is something I've alluded to a little bit, is this idea that if you know that there are these 4 processes or mechanisms of motor learning that you have access to as a clinician, and in theory your patient's nervous system has access to, by which they can like drive neuroplasticity in their own nervous system and change their behaviors, then you can choose to strategically, through your intervention, manipulate the drivers of each of those motor learning processes through the structure, right? So what type of feedback you're providing, what bolus size are you providing, those kinds of things, so that you can specifically target or engage different areas of the brain. And we didn't talk in a lot of detail about the different features of each of these mechanisms, but some are more cognitively demanding and some are less cognitively demanding. Each of them maps on to neuroplasticity in a different part of the brain, or changes in the synaptic activity in different parts of the brain. And so you can consider what part of the brain is damaged, or how cognitively intact is my patient, for example, and then what processes do they have access to right now to change the behavior that we're trying to change here. And then so you can really be intentional about how you design your intervention to promote a change in swallowing, given this knowledge of changes in the nervous system can underlie changes in behavior.
So I just wrote down the question, how can we best decide on which approach to use? So that's what you just said, is it?
Yes, it's okay. I will be full disclosure. There's not a lot of the evidence that says this is the best approach for X right now, for example.
Okay.
But I think the power of understanding the evidence at this point is that you can take what we know already and try to implement it in the clinic. You translate the knowledge that we have right now and see how it goes. But there aren't at the moment, a lot of clinical trials, for example, that have designed the intervention based on these principles. We're not far enough along in our understanding of the motor learning processes to see that in the rehabilitation field yet. But I would empower people to take what we do know about the motor learning mechanisms and start to integrate that into their care. There's be no harm in doing that, So I think that at this point, what the challenge is perhaps is just kind of integrating this information into our working knowledge of motor learning. So now the definition that we started with were the processes associated with practice and experience. We now understand what those processes are, so we can use that information to enrich our understanding and our motivation for intervention design. And I think there's a lot of room for innovation in clinical practice with this understanding of motor learning.
Yes, absolutely. We have reached the end of this episode. Could you maybe summarize the most important points regarding motor learning?
The most important parts of understanding motor learning for neurorehabilitation practice is to be aware that there are multiple processes that underlie changes in a movement or a motor behavior. And those processes each have distinct features and engage different parts of the brain. And because of that, it means that we can manipulate them as if they work independently. And as clinicians, we can use that to our advantage to really try to drive changes in our patients by using the current base of evidence that exists related to motor learning.
Perfect. Thank you so much, Kristan. We really appreciate it. And I think this is really something interesting and helpful for our field, and especially as dysphagia clinicians, and we can learn so much more about this. We hope, of course, that you, our listeners, enjoyed this episode as well. If you would like to get in touch with us and stay informed about upcoming episodes, you can follow us on Instagram at Dysphagia Matters, on Twitter at DysphagiaPcast, or visit our website, dysphagiamatters.org. Thanks so much for listening. Thank you, Kristan, for coming on the show, and take care, everyone.
Thank you.